Welcome to Mind Tricks Radio, where we'll explore contemporary topics in psychology through interviewing creative and innovative thinkers in the field. I'm your host, Dr. Aaron Kaplan. Thanks for tuning in. We're here today with Dr. Arthur Kleinman, author of The Soul of Care, The Moral Education of a Husband and a Doctor. Dr. Kleinman is one of the most renowned and influential scholars and writers on psychiatry, anthropology, global health, and cultural humanistic issues in medicine. Educated at Stanford University and Stanford Medical School, he has taught at Harvard for over 40 years, professor of psychiatry and of medical anthropology at Harvard Medical School and at the Esther and Sidney Rabb Professor of Anthropology in Harvard's Faculty of Arts and Sciences. He was the Fung Director of Harvard's Asia Center from 2008 to 2016. He is the author of 6 other books, including The Illness Narratives, Suffering, Healing, and the Human Condition, widely taught in medical schools. He is a member of the National Academy of Medicine and of the American Academy of Arts and Sciences. Dr. Kleinman is currently directing a project on social technology for global aging and elder care in China that involves faculty and students from 6 of Harvard schools, as well as a number of his former students who are professors in China. Arthur, welcome to the show.
Thank you for having me.
I want to say it's just a real honor to have you here. I consider you a rock star in the field, and you were a huge inspiration for me getting into the field to begin with. Way back when I read Rethinking Psychiatry, which was one of your early books, and a lot of your writings, it got me very curious and interested in the field of the intersection of culture and psychology. And just to have you on the show is just having like a hero on the show for me.
Oh,
so I'm
great.
so thrilled to have you here.
Thank you for saying those things. Yeah.
Well, so we're here to talk about your more recent book, The Soul of Care, The Moral Education of a Husband and a Doctor. And I want to dive into the meat of that book and the meaning of the book to you as we go on with the interview.
Sure.
To begin with, I would really love to just get a little bit of background from you about who you are as a person and a professional and kind of your career and personal trajectory so we get a better sense of who you are.
Yeah, of course. Well, I'm a New Yorker, so even though I've been in Boston and in Cambridge, Massachusetts for almost a half a century, I grew up in New York, and many of my interests are those that came out of being a New Yorker. I am a medical anthropologist, a physician, a psychiatrist. I've done a lot of my cross-cultural work in China, and I've been very deeply involved in what is now called the medical humanities, which is bringing humanities-style thinking, history, anthropology, literature, etc., to understanding illness and treatment. Since I've been a clinician for a large part of my life, though I'm retired now from it, my focus has always been on caregiving, and thought I knew a lot about that from my research and theorizing, but realized that I didn't know a hell of a lot about what really mattered for me when I took care of my late wife, Joan, for 10 years with her early onset Alzheimer's disease. And I was her family carer for 10 years, and until she died from that awful disease. During that period, I learned a hell of a lot about caregiving. That's why I wrote the book, The Soul of Care. You know, my own biography recognizes that when I was young, I didn't really understand care. I came out of a well-to-do New York family. It's a family that had maids in the 1940s. I was raised in a kind of wantonly careless manner. Others picked up things that I dropped. I didn't know how to make my bed. said until I was about 12. Little was demanded of me in the way of responsibility for caring. And of course, caring means not just giving care, but actually worrying, thinking, and planning, and then doing. And so I wasn't raised with any of that. And I learned it in a variety of ways. One, largely from my late wife, Joan Kleinman, who was remarkable in giving care to me and my adult children now, and when they were young, and our friends and community. She was just a careful, caring person who took care of me for the first 36 years of a 46-year marriage. And then I took care of her for the last 10 years. So I learned it from her. I learned it from my patients, the best of whom, in terms of outcome, taught me that care is reciprocal, and it's not just one-sided giving, but it's a reciprocity. I had many patients. And I learned it from my research on patient experiences. Much of my career has been taken up with the phenomenology, if you will, of patients and their families. That is, what is illness? How is it lived? What is treatment? How is it lived? All those things were central to my work. So in my first book, Patients and Healers in the Context of Culture, was about that. And then I wrote a popular book, The Illness Narratives, way back in 1988. Now there are plenty of books written about narratives, but that was really one of the first books written about illness narratives, and using illness narratives to understand what was at stake for patients and families in the illness and the care. From that book, I went on to all kinds of research relating to people's experiences of suffering, whether from a medical illness or from everyday social life, like poverty, or disasters, like China's Cultural Revolution. And in studying these things, I learned how people survive, how they endure. And a lot of that is about care. So those, plus this very practical experience of taking care of my wife for 10 years, and I mean taking care of her, so that with her, Alzheimer's started in her occipital lobes of the brain, which is the place where we interpret images. So she was functionally blind for much of that time, as well as suffering from dementia. I took care of her in ways that I never imagined I would be able to do, such as bathing her, toileting, feeding, ambulating. At the end, I did virtually everything. And then when she became too physically impaired by end-stage Alzheimer's and was on her way to her last few months, I arranged for her to be in a nursing home because I couldn't do all the things that a nursing home at the end can do. Lifting her had become a bit of a problem for me. In that nursing home, I was there with her every day. I provided round-the-clock nursing care. At the end of that period of months, we had a death vigil for her. And so what I learned from all of that could be stated the following way, that care is first about relationships. And the quality of the relationship you have has a lot to do with the quality of care that's going to be given. Oh, sure, there are people who rise above troubled relationships and commit themselves to giving high quality care. But most of the time, if you have a broken relationship, you're going to have broken care.
Hmm.
And that means that some people will refuse to give family care because they feel the person who requires it is not someone they respect or has respected them.
Yeah, sure. You mentioned several examples of that in your book of people you had come across, patients who were in a situation where they needed to do caregiving and were very resentful and upset about that because the quality of that relationship
Yeah.
was not good during the course of their life. Whereas, of course, your love and compassion for Joan was amazing. And I'm sure in a large part because she was so kind and loving to you during the course of your marriage.
Right. And so that's it. That's reciprocity. So that back and forth. If you think of a marriage as the arc of a set of relations between people, and you think of a family in the same way, just more people involved, then care is reciprocal throughout marriage, throughout the building of a family. You are both giving and receiving care. When someone is sick, when kids are small and need to be really taken care of, when accidents happen, there's trauma, when there's COVID, et cetera. All those things add up to opportunities or burdens of care.
Mm-hmm.
And that's important. The whether care is an opportunity to express love or a burden that's resented. In the course of long-term care, like 10 years of taking care of someone with Alzheimer's, it's a long period of time.
Yeah.
Everyone gets frustrated. But if you have a strong relationship, that love carries you through the frustrations. And there are many. There are many frustrations.
Mm-hmm.
If you have a difficult relationship, it makes it harder. And of course, crucial to this are resources. First, financial resources. Care can be very expensive. Alzheimer's is the most expensive disease in our healthcare system. Alzheimer's routinely produces bankruptcy in families, okay, because it is so expensive. Well, I had the financial resources. If you don't have the financial resources, you're in a much more vulnerable situation to have problems with care. I had the financial resources, thank God. And secondly, I had the cognitive resources. Care is about knowledge of how you get help for certain things, where you go to get that help. It's about knowledge of the progression of an illness, knowledge of treatments. In Alzheimer's, of course, even till today, there are no treatments really that are effective, but there are plenty of treatments that are presented to you as something you should try. And the knowledge of when to try something and when to say no, that's a really important resource. So I had the medical knowledge, being a physician myself. I had the academic knowledge of the research. So I didn't have the wool pull over my eyes by all the claims that are made for medications. I knew that the medications have modest or any effect on the progression of the disorder. I didn't expect much from the medications. But when my wife suffered not only dementia, but agitation, which is a big part of the end stage of dementia, knowledge of the relevant psychiatric medications that ameliorated her behavior somewhat. And when she became so angry and frustrated, as anyone would with this terrible disease,
Yeah.
I had knowledge of, and I had the connections to be helped. So that's a big deal. That's a big part of it. Part of the book is pointing out that even with those connections, even with that knowledge, so broken is our healthcare system, so chaotic, so lacking in warmth, personal warmth, presence, and empathy, that even I had difficulty with it with all the connections I had. So, I'd been at Harvard for 40 years. I knew everyone on the medical side, or just about. My friends were some of the leading neurologists who were specialized in this disorder. And yet what I found was that once they had made the diagnosis, and that was an enormous help because it was so confusing at the beginning, but once they had made diagnosis, they kind of lost interest, and also they didn't have much to add. And that was sad, because if you think of neurologists, they're the ones who treat patients and families with a patient with stroke, neurodegenerative diseases like Alzheimer's, ALS, other neurodegenerative disorders, multiple sclerosis, etc. They're the ones who treat conditions that require a tremendous amount from family members in giving care. And yet they're not interested in that. Their interest, and I think it's the interest of most of the field, is focused on the diagnosis, which is important, and the limited treatments they have, but doesn't extend to the aftercare, which is really what these disorders are about. In Alzheimer's, where you don't know the cause, you don't have the medications, there probably are a dozen different syndromes under one name. Care is everything. So that was discouraging for me. That was a very discouraging aspect of things. I came to realize that the medical system was broken when it came to care.
Yeah. I want to follow up with some questions about your observations of the medical system in a moment, in what you're talking about. But just to back up for a moment here, in your situation, your ability to provide care in many ways was ideal. You had the financial resources, you had connections to the community,
right.
You had a wife who you just adored and wanted to be there for her. And you talk a little bit about, in your book, quite a bit, about this idea of, it just gets so hard to see your loved one in such a difficult position as the dementia progresses. Yeah. And I mean, it's sort of heart-wrenching reading about what Joan was like, especially toward the ends of her illness when she had Capgras syndrome, which is thinking her husband was an imposter and yelling at you for that and throwing these tantrums and fits and being unable to calm her. And I guess the question that people would have who haven't gone through that is, how do you manage as an individual? What needs to happen for you to keep going to care for somebody when it's so difficult like that?
Yeah, well, you get it. See, you get it. A lot of people don't get that. That is the question. Well, you need all the help you can get. So I had a wonderful home health aide. I had the finances to afford a home health aide who could work, as she put it, 9 to 5, and then I worked 5 to 9 and during the weekdays. Mm-hmm. She worked from 9 in the morning till 5 in the afternoon. I worked from 5 in the afternoon till 9 in the morning, and then I worked on the weekends. But that was enormous help. That allowed me to continue to go to work, have an income, and also keep myself going. Okay, mm-hmm. That's very important for a family carer, to have things that keep you going. So a home health aide. I had a substantial house with a garden that made it possible for Joan to be at home a fair amount of the time. I had friends who were, some of whom, not all of them, but some of whom were very supportive and helpful. And the local community that I lived in, which I had lived in for a long time, really gave assistance. So that, for example, when Joan went with our home health aide or with me to the bank or to a store, we have a little community where I live called Huron Village in Cambridge. And we've lived here for so long, people knew Joan so well that even though she became cognitively inadequate to to complete things like a banking engagement, having to take something out of the bank or put something in. They helped her with that. And I remember that our local Whole Foods, the cashiers who knew her very well, most of whom actually were from Islamic countries, who wore headdresses, they went out of their way to calm her and help her. She would get upset sometimes by, for example, once I remember the color of the receipt that we were given when I was with her was something that surprised her, and she thought there was something odd, strange going on. Rather than participate in a worsening situation or make the situation worse, these local people contributed to making it calmer, better. And, that was no small thing. And as I said, I had the resources to understand what was happening so that at the beginning of things, I realized that this was a progressive disease and that where I was getting comfortable at a level of taking care of her would only last for a few weeks or months at the most. And then she was going to slip to another level and had to start all over learning how to deal with things. So, for example, at the beginning, when Joan had to be bathed or bathe herself, I just accompanied her into the bathroom and held things for her and helped her do it. But at the end, I had to do everything. Okay. And so you slip, it's like a slope that you're going down and you're hoping that the angle of descent is not too sharp.
Yeah.
Because maybe then you'll fall down. And that's one thing that I think is really important for caregiving for a disorder, a progressive disorder like Alzheimer's. This is different kind of caregiving than caregiving when you have a little baby or a child. You know that everything is going to become more independent over time. It may take years to get there, but eventually with a baby, you're going to have a toddler. And for a toddler, you're going to have a youngster. That very hopeful movement is just reversed in a disorder like Alzheimer's or any progressive end-of-life disorder. It's going to go down and ultimately take your life.
Yeah.
So I had that. I knew that. I had that recognition. I knew we would end with hospice. I knew that death, we would have to deal with death at the end. All of those things gave me an advantage. I think that if you're coming into this and you don't have much experience in the health domain, you really have to learn fast about how it progresses. And the way the disease is described by professionals, in my view, is not a very useful way. It's described in terms of very large block statements. Early Alzheimer's, middle Alzheimer's, late Alzheimer's, or mild, moderate, severe. They're too crude. They're too crude and they're not helpful. What you need is to have, for each stage, to have the issues for family care laid out. What are those issues? So in early Alzheimer's, especially in early onset Alzheimer's, because these are people who are not in their 80s, but in their 50s or even 40s. Joan was in her late 50s when this started. Part of the problem is denial. That is, people with the early signs of cognitive decline, especially at a young age, they're in a kind of physiological denial. It's not even a psychological denial. It's the brain itself denying that there's a problem. And that's very difficult to deal with, because that means that people will say, well, I'm not as bad as you think I am, and that's where, things happen, where someone has to stop driving, which is a big deal in the United States. Just as big, someone has to stop going to work. My wife was a great researcher. Someone ultimately is going to lose their skills at their, what you might call hobbies, or for Joan, They really were her life. Painting in the Chinese style, calligraphy, all those things were going to go, and they went. So in the early stages, it's a series of losses that you're dealing with. In the middle stages, it's the intersection of cognitive decline and behavioral change. And increasingly, the behaviors become more difficult. You mentioned Capgras syndrome. That's a really tough one, because in Capgras syndrome, not just you, but the environment seems like it's phony, fake to the person. It's a delusion about the setting that leads you to believe that this is not real. This setting's not real. This is not my husband. This is not my home, etc. That can be very, very disruptive. Other delusions that are there, you get a paranoid period of suspicions in Alzheimer's, as someone can't work through the different sensory information that comes in and make a clear decision or understand things clearly. All of that leads to paranoia, suspicions. Later on, as you get to more advanced Alzheimer's, agitation, agitation, real agitation. I mean, someone who's so agitated they can't sit down, they can't stop trembling, they can't stop to think or to respond. Agitation so bad that an individual develops a kind of delirium and becomes wild, throwing things, just in a delirious state. If we had a careful handbook, easy to read handbook for conditions like this, set out for the family, I think it would define problems at different stages and suggest solutions. Okay. Suggest solutions, because so important is context here. Relationships, income, support system, etc. You can't universalize. It has to be more specific. But that, I found the absence of that difficult to deal with, because you would have liked to know what you should prepare yourself for. So you end up reading memoirs of people who went through Alzheimer's or family members who took care of Alzheimer's. And that's interesting, but it's got to be brought together in some way that makes it useful to you. And that's what I try to do in the book, by identifying relationships, presence as key elements of this. Relationships meaning reciprocity. It's so easy when we think of relationships only to think about the caregiver, as you watch the Alzheimer's patient begin to disappear, as it were. They speak less, they respond less, but they are there, and your interaction with them is reciprocal. Okay? And so emphasizing that reciprocity, very important. Presence, you're being there just the way I am with you now, in an intense way meant to convey some feelings, some ideas, and not mechanical, okay? But if when you go into the hospital, frequently what you discover in the hospital and the clinic is a very mechanical way of dealing with patients and family members. At the beginning, one of the problems is, how do you include the family member? Given our tremendous emphasis in the United States on the autonomy of the person, in this case, then the autonomy of the patient, when do you start including the family member? Okay. Well, clearly, by the time the patient can't respond, the family member's got to be included. But there's a long period of time where decisions have to be made about guardianship, about health proxies, about not driving any longer, about having a spouse or a family member having power of attorney so that there is access to someone's funds that can be used in this regard when the person involved can no longer write a check or can't remember what bank they're involved in. Okay, so all these things I think are what I call, sort of the daily frustrations that require you to be present, but where increasingly you begin to feel like maybe you can't be present all the time. And so I think what brings the presence out is the relationship. That relationship, if that's based in love, it's that person who's sick, who's bringing out of you the presence, your presence. And they're bringing their presence to the best that they can. Second, the third thing is rituals. Rituals are very important, rituals and habits. You're going to get through 10 years of caregiving. Everything cannot be spontaneous or just done at a moment's whim or sort of forgotten about now, but picked up later. You want to organize each day so that it becomes easier to get through. And those are rituals. So you go through a kind of ritualized organization to how you do things like bathe someone or cook a breakfast and help someone eat it or go for a walk together. All of that becomes ritualized, and that helps you get through days. And then, there's the enduring. I think that this is also something that most Americans do not experience. Fortunately, we've had so many things that have helped us in life that if you're in a middle class in America, you don't think about just enduring something. You think about doing well, having a great time, the beauty of things, the aesthetic pleasure. But if you're poor, if you're marginal, if you're really sick, if you have Alzheimer's and you're a family caregiver, you realize you've got to learn how to endure. Just like the patient has got to endure this terrible disease, so does the family member. And for care to occur, you've got to endure pressures and difficulties. And these are very pragmatic. So I remember a number of times where I just wasn't sure I could endure anymore. I remember Joan, who was such a beautiful woman, so private, so discreet, so careful in herself, when she began to lose continence of urine and feces, it was so troubling to me. I wasn't sure that I could take care of her anymore with that. And I learned I could. And I learned I could because she helped me learn that. I remember when the first time that she lost control of her bowels and there was feces all over the floor, and I started to cry. She said, "You can do it, Arthur. You can do it. Just clean it up now." And that's what I did. I cleaned it up and endured it. And I think that endurance means something's got to keep you going. You've got to feel you can keep going. And that means you got to take care of yourself. That's what the home health aid did for me. Gave me time to be away from it, to recharge my batteries, to get my mind in another place, and then to come and take care of things. That's what family support did for my daughter and son, adult daughter and son, who were just fantastic in this. Even my mother was very, very helpful in this care of Joan. So that's what keeps you going. And, for others, it's a religious, spiritual commitment. For me, it was a kind of moral commitment to know that it was there to do, and I was responsible to do it. I once wrote the foreword to a book called The Caregiver, written by E.S. Goldman, who was a writer for The New Yorker. And under the name Aaron Altera, he published this book, The Caregiver, talking about taking care of his wife with Alzheimer's. And because the book was well received, and there was a reading from the book at a bookstore in Cambridge. And because I had written the foreword, I was asked to come and comment as well. And here was this man, the author, who was well in his 80s at that time, maybe 87, 88, had to use a walker, but completely clear in his mind, talking about this book and what caring for his wife had been about. And all of a sudden, there's a question from the audience. A young woman, clearly, who had never had an experience like this, said, well, why did you do it? Why did you do all these things? And I could see, standing very close to this great writer, Mr. Goldman, that he was stunned by the question. He was absolutely stunned by the question. And at first, he asked her to, clarify it because he didn't understand it. And she said, well, you didn't have to do all these things, Why did you do it? How did you do it? And he said, well, it was there to do. It had to be done, And he thought for a minute, and then he said, it was the vows, the marriage vows. It was the quality of the relationship. What was I to do other than this? This is what I was there for, to do it. Had to be done. I just liked that very much because I felt that was my answer. That's what I said. That why did you do this? Because it was there to do. I love Joan. I wanted to give her the best of care. It was there. I never thought about it. I just did it. And you're a caregiver while you're doing it. But I don't want to romanticize care because I think people have to just understand that you can do it, but it's difficult to do. It's financially difficult. It's emotionally difficult. It's physically difficult to do. Okay. But it needs to be done. And I think that's the world I came out of. And that's the world I hope we're still in, where people make moral commitments to each other, to be there in good times and bad times, to share and to let their love lead them to places where they never imagined they would be.
Yeah, you make that point in your book in several occasions, and I thought that was a very important point because I think many people who have never been in that position before, it's hard for them to imagine how could somebody endure, and rise to the occasion of taking care of somebody.
Yeah.
And I guess when somebody is in that situation, they just do it. They just do it. There wasn't a lot of thought about whether they can or can't do it. It's just you're called to rise to that occasion and you do it.
You do it.
Yeah.
You do it. Yeah. I think if you think of more broadly of catastrophes, because this is a catastrophe. Alzheimer's is a catastrophe.
Yeah.
It's the same as why do people in a fire come out and try to help other people? There's a catastrophe. Something has to be done. You can't just stand there. That's the moral commitment that you're going to do something. I've always believed, and it's central to my teaching and my research and my writing, that providing care, doing good in the world, is a way of doing good in the world.
Mm-hmm.
And that we're here to do good in the world. No matter what your job is, no matter what your education, what your income, there are ways that you can do good in the world. And we all know that. And I think that care gives you a great sense that you're doing something important, significant. Now, is that always enough to keep you going? No. You can be so frustrated, etc. Now, this is what you see translates from the family care to physicians and nurses. So more than 50% of physicians in America who are in primary care and nurses in the same place, more than 50% have the symptoms of burnout.
Mm-hmm.
Okay. Why do they burn out? A lot of people have asked me, why do they burn out? I think they burn out because they're alienated in healthcare systems that don't allow them to do the caregiving that they want to do, that make them see patients very quickly and just prescribe a drug here or there, but not really do the care for patients, that are in systems, and when they do give good care, they don't get rewarded for it.
Mm-hmm.
They're not recognized, etc. When I started medical school in 1962, you really did feel that medicine was a special kind of practice. And now that I'm finishing up, I'll retire in a couple of years. I'm 81 years of age now. The practice of medicine is more like a worker on the factory floor. So one of the things that's happened is that the profession has lost its autonomy, lost its ability to articulate care as a central virtue of the practitioner, and instead has to use the same economic language that everything else is put in our society. And that language leads to a kind of indifference of people who are in institutional settings, who basically have become, in the health system, bureaucrats. Even though they're doctors, they're bureaucrats. They're part of a huge organization. They are treated as if they are simply employees. They lose the sense of medicine as a profession committed to healing, committed to doing the best you can for patients. And I think under that, nonetheless, they struggle. 90% of doctors, I'm convinced, struggle to give the very best of care.
Mm-hmm.
They burn out when they realize they simply can't do it, because the system has been set up not to provide high quality care, but simply to provide efficiency, institutional efficiency. In fact, that's how we measure care. We have no direct measures of care in the healthcare system. What we measure is the efficiency of the hospital, of the clinic, of the healthcare plan. That is not care. Okay.
Yeah.
In order to measure care, you'd have to measure what I've been talking about: quality of relationship, quality of communication, time spent, how you listen, how you respond, what you do, etc. We don't measure any of those things.
Yeah, I mean, I thought that I really enjoyed the part of your book where you were talking about your early experiences as, I guess, as a medical student or even as a resident, where you were doing the home visits. You were spending the time to really hear the story of the patient and see the environment where they were living. And you began to understand the importance of learning about and understanding the patient in a broader context, and just seeing a patient for 3 minutes, diagnosing them and sending them on their way, discards so much important information. There's one story you said that was, I think, a perfect highlight of it. You were talking about a woman who had some kind of a medical condition where I can't remember exactly what was happening, but she was maybe having bladder infections or kidney infections or something. She wouldn't urinate because the urinating would be losing water, and she was being told.
Let me tell you what it was.
Yeah.
This was a woman. This was very interesting. I did my residency at the Massachusetts General Hospital. This was at the Massachusetts General Hospital in the early 70s. This was a woman who was the wife and daughter of plumbers. She was not well educated herself. She had congestive heart failure. And she was told by the doctors that she had too much water, that her heart was failing and she has too much water in her body, and she had to get rid of that water.
I see, yes.
That's how they were describing the failing heart, the hypertension that she had, the salt retention, etc. And so she was doing everything she could to get rid of that water. She was vomiting, she was urinating even in the bed, and they thought she was psychotic.
Right.
They thought she was, because no one had spoken to her and simply asked her, why are you doing this? Okay. Yeah. She would have told them. She was, very articulate in that way, even though that she didn't understand the physiology of things. That's a mixed bag. So the situation today is much better from the standpoint of patients. We have patients and families are much better educated about the body, about medicine, about health. There's a more democratized element to healthcare where the voices of patients are being encouraged and heard. But still, the structures of care emphasize this efficiency. And if we're honest, it's not just any efficiency. It's that all the healthcare system, including the huge number of hospitals which are supposed to be, quote unquote, non-profit, are not non-profit. In effect, when you look at what they do, they generate surpluses, they generate income, okay? They make money, right? And I think that that's one of the things that's very problematic in a capitalist society.
Yeah.
Can you have a good system that gives care when the system turns on making money? I don't think so. I think that care sometimes is very costly. You're not going to make money off of it. And there's something more important than making money in life, in my view, it should be for doctors, and that is giving good care and for family members. You know, part of our problem is the nature of the kind of capitalism we have in America, as opposed to, say, in Japan or the Netherlands or Germany or all of Scandinavia, from Finland to Denmark. They have national healthcare systems that, for a problem like Alzheimer's, they provide you with long-term care insurance. You get a home health aid, okay? I had to pay for that home health aid. I had the resources to pay that. Most Americans, I think, don't have the resources for that.
Yeah.
And our system doesn't help them in that regard. You need a system that has long-term health insurance. Most Americans do not have long-term health insurance. Mm-hmm. When they get to problems like Alzheimer's at end of life, they're going to have real problems at that stage, problems affording things. We take for granted that this should be the responsibility of the families. But I believe this is the responsibility in part of the state. Mm-hmm. The government should have responsibility for this, especially for the uneven playing field that we start with. In health, we have a greatly uneven playing field. In my view, that is the central ethical problem in our system, which is that we have people in our system who are poor, very poor, who are marginal, who've been discriminated against, who have no resources. You can't simply have a situation like that without prioritizing them. They need to be prioritized. This is my former student who just died, Paul Farmer, who was a great medical humanitarian, an icon of global health. This is what he said: the prioritization of the poor patient should come first. Okay. Mm-hmm. You know, we don't live in a system like that. So not being in that kind of system, a lot of people are not going to get much help. And not only are they not going to get much help, they haven't accrued much wealth to begin with. They're not given good health insurance, if any health insurance. They're going to have a member getting a disastrous disease, a catastrophic disease that requires resources. And this produces, I think, in a setting of poverty, this makes poverty bite even much harder. It's what grinds people. Mm-hmm. Okay. And so I think that I was enormously privileged to give care. I am enormously privileged. What our system should be concerned with is those who are unprivileged, who don't have the resources. And if you don't have the resources, how in the world can you give the care? Okay.
Yeah, well, as you mentioned, the care, especially for a long-term illness such as dementia, requires so many more elements than just writing a script and taking the medication, because the care requires, it can become 24/7 care on so many different levels, and that's just not acknowledged.
So look where that leads. So that leads to the fact that nursing homes are ultimately paid for by Medicaid. So if you're an elderly person and you've spent down your resources, all your resources, then Medicaid will pay for a nursing home. But what kind of a nursing home will it pay for? It'll pay for a nursing home that your family and you would never want to be in.
Yeah.
By and large, a nursing home where you don't even have to open your eyes when you walk in, you just smell the urine that's over places. A nursing home where there aren't insufficient numbers of health aides helping people.
Yeah.
Not enough nurses, hardly any doctors.
Yeah, you described in your book visiting many of those and how demoralizing it was to see it.
And these are the places under COVID where people have, at the beginning of our pandemic, just died, in large numbers.
Yeah.
Not surprisingly. Care may start with the issue of, Alzheimer's or end-stage cancer or heart failure, but ultimately, as you take the subject seriously, it brings into account just how we live our lives and the structure of our society. That's what's so interesting about it. And once you see things from that perspective, and that is, I'm an anthropologist as well as a physician, that's how I see things. Once you see things from that perspective, then you are really attracted to the immense health and social inequalities in our society. And I have no idea how a poor family takes care of a family member with Alzheimer's in our society.
Yeah. Arthur, I wanted to ask you one last question here, kind of bringing it back to the personal again.
Yeah.
And this sort of existential idea of meaning and purpose that caregiving can bring to a person. You talk a bit about that, especially toward the end of The Soul of Care. And in what ways do you think you or other people might grow and derive meaning in their lives existentially from going through an experience like what you had?
Yeah. Okay. So there was a report about 5 or 6 years ago by the National Academy of Medicine called Families Caring for an Aging America. And in that report, they showed the evidence that if you're a family caregiver, you're under such stress and for serious illness that you're likely to have disorders you might not have had if you had not been under that pressure. And you're likely to die earlier than those of your friends who don't have that kind of burden. Okay? But they showed something else as well, that you're also more likely to have worked out what the purpose of your life is and your role as a caregiver, and have a sense of meaningful aging, that there's meaning in what you're doing. Because I think care provides that meaning. It's what we're here for. You come to realize that care is the glue that holds our society together. If we didn't have it, if we were all wantonly careless, we wouldn't have a society. Okay. And you realize in your own life that this is your opportunity to do good in the world and to help someone you love. And I think that's when it comes down to it, at the end, where do we get our meanings from? Well, we get our meanings from our religious background, from the moral commitments of our group, et cetera, the local worlds we live in. But ultimately, in our individual lives, we work out meaning with respect to those around us and ourselves. And care is central to that. I think care is what gives meaning to people's lives. Now, it's not the only thing that gives meaning to people's lives, but it's an enormously important thing that gives meaning to people's lives. If I were back in the same situation, knowing what I know now, would I have done the same thing? Absolutely, I would have done the same thing. Even though it produced days and nights that were so difficult and painful and so much sorrow and difficulty, frustration. I would have done the same thing over again. And I think I would have done it just the way that we talked about it earlier, as something there that needed to be done, and you just do it. Okay.
Yeah.
And later on, you make kind of sense of it. But while you're doing it, there's something in you vital that energizes you, that keeps you going. And I think ultimately that's the embodied recognition of purpose, that there's a purpose in living, that we're not just thrown here in the world without any significance, and that purpose is around caring for things that matter. Now, but here I mean something broader than just caring for another person. I think we see this in the way people care for their gardens, care for their pets, care for their hobbies, care for their work. I think that, Freud said work and love were the two things that keep you going. Well, I think love is one of the things that keep you going, but it can be any kind of care that keeps you going. And I think that's not a bad way to end up in life, to have a sense that you put your effort into caring for someone who you love. And I look back on my career, I've had all the honors, all the prizes. I've had every advantage. I think that difficult time for me was the most important time in my life.
Well, it really shows in your writing, Arthur. It was such a moving read, and I really enjoyed hearing your thoughts and your sort of stream of consciousness about the experience that you had with Joan, and then also weaving in some of the broader, political and social thoughts about it, putting it in perspective. Yeah. But it was just really a beautiful and wonderful read. So I thank you for that.
Well, thanks for the interview and my chance to, explicate the book. And I hope people who listen will read the book. And especially, I think people who are faced with what I was faced with, I hope they'll read the book, because in a way, that's the book I wanted and needed when I started. Yeah. Thank you so much.
Thanks, Arthur. It's been a pleasure having you on the show, and keep up all the amazing work that you do.
All the best to you. Bye-bye.
Thank you for listening to Mind Tricks Radio. I hope you have enjoyed the program. For more information about Mind Tricks, you can go to my website, www.waikikihealth.com. Be sure to subscribe to Mind Tricks on your preferred podcasting host to be notified of new episodes of Mind Tricks. Please take some time to give Mind Tricks a good rating and review wherever you're listening. It really helps get the word out to new listeners. And please like and share Mind Tricks posts on Twitter and Facebook by following your host, Dr. Aaron Kaplan.